Happy National APP Week. I'm Dr. Chad Swanson, and I'm on a journey to understand and transform our health system. I'm grateful for the physician's assistant, nurse practitioners, certified nurse midwives, certified registered nurse anesthetists, and other advanced practice providers that I've associated with over the years. Now, what is the ideal role for these advanced practice providers in our health system today? In my experience as an emergency physician, I've worked directly with a number of physician's assistants. I've been cared for by physician's assistants and nurse practitioners. A lady that I admire more than almost anyone else was a certified nurse midwife. So I have a lot of respect and admiration and gratitude for advanced practice providers. In order to understand the ideal role of these health professionals in our health system, I think it's crucial to understand the history and focus of our medical degree making, diplomas, our licensing, our board certification. And so let's go back in time to the 1840s. At that time, our country was largely rural. There were little to no hospitals. There was very inconsistent and often no licensing requirements for physicians. Medical education was a cottage industry, meaning there were, in many ways, way too many medical schools. They were run as profit-making machines where the faculty would get paid based on the number of medical students that arrived. There was little to no regulation, essentially no regulation, meaning that they could teach about whatever they wanted to teach. Many times physicians would graduate with little to no clinical experience. There was very little scientific understanding of medicine and disease. There were very little, if any, nurses at this time. There were no medical specialties to speak of. Public health wasn't a discipline that was very well established at all. Much of the health improvement that would go on was done in the home, it was done in communities, it was done by natural healers. And from a scientific perspective, there wasn't much that medicine could do to offer. In fact, due to the fact that bloodletting was used and other medicines that would often do more harm than good, you could argue that physicians were decreasing the life expectancy and quality of life. There was also a significant amount of inequitable health outcomes. So health status was driven by largely infectious diseases. Interventions like improving water cleanliness could make a big difference in the lifespan of an individual. And so the poor in the country, often people of color, Irish immigrants, etc., would not live nearly as long as people that were more wealthy. There were a number of alternative or irregular medical sects. So homeopaths, eclectics, naturopaths, Thomsonians, and there was a large amount of competition among these different sects for patients to earn money. I learned yesterday in some reading that chiropractors in the 1890s were put in jail if they didn't abide by the requirements that the regular physicians or the allopaths or what would become known as the MDs would put in place. So to address this situation, the so-called regular physicians or allopathic physicians, what we call MDs today, formed the American Medical Association in 1847. So this was an organization that was set up, at least in theory, to place a scientific basis on medical education and medical ethics. It could be argued, and many historians have argued, and it's my sense that a large driving force, maybe the primary driving force, was financial. So to solidify and organize and increase the power of the profession so that regular physicians could then gain a monopoly on their profession and increase their income. I'm basing much of my knowledge on this subject on really a classic in medical history called The Social Transformation of American Medicine. The book that won the Pulitzer Prize back in the 1980s. If you're interested in this topic, I strongly recommend it. So as time went by, the scientific method gradually seeped its way into the medical establishment, so that when we got to the 1890s, there were a number of possible ways forward. So there were some physicians that were advocating for a national health system, one that would focus on population level interventions that could improve the health and well-being of the country. There were people that were more focused on community-based interventions. There were physicians leading the way that were advocating for individual medical treatment, such as surgery, that could improve the health of patients. So in the 1890s, antisepsis, or the performance of surgery and operations in a very clean and sterile way, started to really gain traction in the United States. It had been 20 or 30 years since the ideas were initially developed in England, and they made their way here to the United States. But finally, at Johns Hopkins and the Mayo Clinic, these ideas of performing surgeries, whether it be for appendicitis or gallbladder or even brain surgery, were showing significant promise. And so this was a time where the medical establishment, we could call it the medical elite, so a number of physicians realized that they could gain the ability to really help people on an individual level. They could also gain prestige and significant financial reward by learning the techniques of antisepsis, but also vaccines were gaining traction, and ideas related to a scientific approach to medicine was gaining traction. And so there was a change from a kind of a Wild West free-for-all to one where there was one approach to medical care that was gaining more traction and more prestige. And so there was a coalition around this vision of biomedical reductionism, that we could improve the health and well-being of people and the country through focusing on the biology and medical interventions, focusing on one system of the body at the time, whether it be the cardiovascular system or the gastrointestinal system or the nervous system, and breaking down each problem into its smallest parts, and then focusing on that part, and then fixing that part, and then move on. So kind of a mechanistic approach to medicine. And funders jumped onto this vision. So the Carnegie Foundation and the Rockefellers really saw promise in this approach to health and medicine. I'm going to take a step back a little bit, and based on the knowledge that we have now, there's a few things that we could recognize. The first is that even considering today's knowledge and expertise, the contributions of doctors, nurses, hospitals, and the rest of the medical system only contributes from 5 to 20% of our overall modifiable health status. So the health status that we can actually change, only 5 to 20%. So the other 80 to 95% is based on things like our social connection, the environment that we live on, our exercise, our diet, etc. And so we shifted from, or we chose as a society to focus on interventions that would only improve our health a small amount. So we chose to focus on rescue treatments. The second comment I want to make is that we also chose to place these providers, so the Johns Hopkins physicians, the Mayo brothers, and others, in a high social state. So we gave them prestige, and physicians started to gain more and more prestige, and financial reward went along with that. Whereas nurses and community leaders and physicians and others that worked on population health and well-being interventions, whether it be vaccinations or improving providing clean water, etc. There wasn't the same level of prestige or financial reward. And so over time, physicians gained more and more influence, power, and money. And so this went on throughout the late 1890s and early 1900s. There was an important report in 1900 by Abraham Flexner. Abraham Flexner was not a scientist, he was an educator, and he was hired by the Carnegie Foundation to go around and do a survey of all the medical schools in the United States. And he came to the conclusion that there were too many medical schools, that Johns Hopkins should be the model. And so due to that report, as well as many other forces over the course of decades, many of the schools closed down. African-American medical schools closed down. Medical schools for women closed down. And really from the time of the early 1900s into the 1950s and 1960s, the medical profession, again, grew into one of driven by rescue treatments, elitism, and financial gain. So in 1965, there were two new professions that emerged. One was at Duke University. They were known as physician's assistants. And there was, let me see if I can find the name of, yeah, I don't have that pulled up anymore, but there was a physician, as I recall, that was at Duke University, and he saw the need for more primary care providers in rural areas. And so he saw these corpsmen from the military that had essentially practiced medicine independently or semi-independently, or using protocols to address the health needs and medical needs of the military. And so he thought that that could be a powerful force in the United States as well. So the profession of physician's assistants was formed. And then at the same time, also in 1965, at the University of Colorado, there was also seen a need and an opportunity to train nurses to have more autonomy, and the profession of nurse practitioners was born. Now, these were kind of exceptions. It's not like nationwide. There was a large a movement necessarily. It was more that two individual groups saw the need within those pockets, and there were champions, and they were visionary. And yet the overall system was still driven by rescue treatment, elitism of the medical profession and these institutions, and profit. So here we are today with hospitals that are ubiquitous and kind of considered to be the center of health systems, and very profit-driven often. We've inherited the licensing requirements, the education requirements from the early 1900s and 1890s. So the idea that a physician should get a bachelor's degree and then do 4 years of medical school, and then do at least 3 years of postgraduate training in residency and an internship have largely been unchanged since the early 1900s. The role of nursing has also remained in many ways as it was set up in the early 1900s as a role to assist in physicians and care at the bedside. Medical specialties have also remained similarly through residencies and fellowships. And so today there are about 400,000 nurse practitioners, about 200,000 physician's assistants, and about 1 million physicians. So nurse practitioners, physician's assistants, along with certified nurse midwives and certified registered nurse anesthetists, are approaching maybe even surpassing the number of physicians. Now, nurse practitioners generally go on to, my understanding, and correct me if I'm wrong, please, but my understanding is that nurse practitioners go through about 2 to 4 years of extra education and training after receiving a registered nurse degree, although some can go directly into a nurse practitioner program. Sometimes it's as low as 18 months. They receive 500 to 750 hours of patient care, whereas physicians receive 12,000 to 16,000 hours of patient care, so 16 times more than nurse practitioners. Physicians assistants, now being called physicians associates, receive 7 years total of training and education compared to 11 years total of physicians and of physicians. So I would say that in an ideal system, it would be possible for a physician's assistant to become a physician, and for a physician to become an advanced practice provider with the appropriate education, additional education and training if needed, based on the individual need of that provider. Let me give 3 examples to make this point. The first, you all may know of or have a primary care provider that's either a nurse practitioner or a physician's associate that has 20 or 30 or 40 years experience or even more, and that practices in many ways on a level with the primary care providers. So while this nurse practitioner got a degree as a nurse practitioner and the other got a degree as a physician, over the years, through ongoing training, through experience, they're both at the same level of knowledge, of skills with procedures, of patient satisfaction, of caring for their patients, etc. And so if that advanced practice provider, if that nurse practitioner wanted to become a physician, wanted to have the opportunities and financial reward that a physician has, she would have to go back to school for 7 years. And from a systems perspective, that makes no sense. We have this provider that has a tremendous amount of knowledge and experience. And so I would advocate for maybe a year, maybe 2 years, maybe 6 months. I'm not sure what the right amount is. And maybe that would be a year of inpatient training in the intensive care unit, in the pediatric intensive care unit, in the emergency department, maybe with orthopedic surgery maybe. But whatever it would take to provide that provider with 20, 30, 40 years of experience, enough to be at a competent level as a physician. Second example, you may know, and I know in my hospital there are physician's assistants in a number of specialties: orthopedic surgery, intensive care medicine, and similarly, these providers have often been in practice for 10, 20, 30, 40 years. And so what would it take for an orthopedic surgeon, physician's assistant, to rise to the level of skill and knowledge of an orthopedic surgeon? Maybe 2 years, maybe 3 years, maybe 4 years, I'm not sure, but I am certain that it wouldn't be the 8 or 9 years that it would require to go through medical school and residency all over again. So again, we have an untapped resource of skills and knowledge in our health system right now. And by creating a means so that healthcare providers with a certain number of knowledge and skills can gain the additional knowledge and skills that is appropriate given their knowledge and experience to gain the degree or the licensing or the board certification in a specific specialty, then that could potentially save a significant amount of money. And there's other advantages as well that I'd like to share. So the third example to make my point of how an adaptive, dynamic approach to licensing and degree granting and board certification would be a family practice physician who's maybe in the later stages of her career. Maybe she's 45, 50 years old. She's been in practice for 20 or 30 years. She's very comfortable with her practice. And yet she's at a point where she'd like to try something new, or she'd like less hours, or whatever the case may be. Maybe she's had a personal experience, would like to be involved more in adolescent psychiatry. And maybe finances aren't as big of a deal for her, but if she had the opportunity to become let's say a pediatric or adolescent psychiatry physician's assistant, maybe with a few months of training or 6 months. I'm not sure exactly what the appropriate amount of training and education would be, but that could potentially have significant benefits as well, such as with burnout. So I see at least 3 advantages to this approach. One is that much of the clinical training that we go through today as physicians in medical school and then in residency is either unpaid or it's paid at a very low amount. So physicians in residency get paid a half or a third of what most advanced practice providers get paid. And so essentially, if we were to allow advanced practice providers to gain the experience and knowledge that they would need to practice at the level of a physician, then much of their knowledge and experience would be gained through a paid experience working in their jobs as they normally would. The second advantage, and so back to the first, I think that this would over time allow for the pay overall of all healthcare providers, professionals to decrease, because there wouldn't be as much investment and lost income to education and training. The second advantage that I see is that the health system workforce would become much more adaptive and nimble to the needs of society. So it's been estimated, and I did a different video on this topic, that up to 86,000 additional physicians will be needed by the year 2036. But it's really hard to predict these things, and often the predictions have been very wrong. And given the flux and the uncertain nature of when healthcare providers will retire, and what the role of the internet or AI will be in healthcare, and the role of these advanced practice providers, it's hard to predict exactly what the need for physicians and other healthcare providers will be. And so as it stands now, we essentially have to plan at least 7 years ahead, because we have to think, okay, a pre-medical student starts medical school and then they won't graduate from residency for another 7 years. So with this more adaptive and nimble approach to health education and training, physicians and advanced practice providers could fill those needs much more quickly, and over time, healthcare professionals could change their specialty or change their area of focus over a course of 1, 2, or 3 years as opposed to 7, 8, or 9 years. And number 3, I think that there would really be less burnout. So there would be much more opportunities for a number of providers. If one orthopedic physician's assistant is orthopedic surgeon physician's assistant is on the pathway to become a orthopedic surgeon, but then realizes that she has a significant hand tremor, then she could switch, be a different PA, and then advance to become a psychiatrist or a radiologist or any other different specialty. So there are a number of challenges with this approach. Number 1, of course, there would need to be a widespread buy-in from governing bodies ranging from the American Association of Medical Colleges to state licensing boards to board certification bodies. And so the second challenge there'd need to be a mechanism to track the clinical experience of these providers. So ranging from the number of patients that a physician or an advanced practice provider sees with a specific condition, to the number of procedures that he or she performs, and those would need to be proctored, or they need to have a mentor to assure that there's a high quality standard. So despite these challenges, as I consider the various challenges of our health system, it's reassuring for me to look into the past and see that in the 1890s and early 1900s, there were tremendous changes from the emergence of hospitals to transformation of health education. So there has been a widespread change in our health system in the past, and I think we can do it in the future. So I'd love your thoughts. I'd love your criticism, your comments. I'm posting a video every day about health systems transformation. I'm focused on a vision of optimal health and well-being for all at the lowest possible cost for the system. The theory and paradigm of complex adaptive systems. And then finally, the need to align all of our incentives with that vision. Thanks.